Greetings. It's really a privilege to be here today with all of you. The topic of my talk is heart failure with preserved ejection fraction, diagnosis, pathophysiology, and epidemiology. Here are my disclosures. Over the next couple of minutes, we will discuss the evolving epidemiology in Hfpef today, some key pathophysiological concepts, and the latest in diagnostic testing for Hfpef. So the epidemiology of Hfpef continues to be a large concern. There are over 6 million adults with heart failure in the United States, and these trends are continuing to be evident around the world. Hfpef accounts for approximately 50% of all heart failure cases, putting us at over 3 million cases in the United States, and the prevalence continues to rise relative to heart failure with reduced ejection fraction. As some historical context, one of the first reports of Hfpef was in the 1980s of a report of leaner body mass women with hypertensive heart disease who presented with flash pulmonary edema and very hypertensive into the emergency department. This presentation of Hfpef has really evolved over the last 20 to 30 years, where we are certainly predominantly seeing patients with metabolic syndrome, obesity, multiple comorbidities, and both women and men being affected with Hfpef and at a younger age. This is a nice schematic from Sanjeev Shah and colleagues to describe this evolution in the phenotype of Hfpef. This really mirrors the prevalence of comorbidities, specifically metabolic comorbidities, such as obesity and diabetes, as shown here by Shannon Dunley and colleagues in a recent review. And we are seeing that the phenotype of Hfpef is mirroring this, and the prevalence is increasing according to these comorbidities as well. So in summary, Hfpef constitutes a major unmet need in cardiovascular medicine from an epidemiologic standpoint. The 1 year post-hospitalization mortality is as high as 30%, with a 5-year mortality of 50%. We remain with limited therapies with any benefit. There is a global sense that phenotyping may help identify better therapies for certain patient groups, and that we have major gaps in our understanding of disease mechanisms today. Overall, more targeted precision-based therapies and clinical trial design and sequence would likely better benefit this population. So from a pathophysiology standpoint, diastolic dysfunction has been one of the key primary underlying abnormalities in Hfpef for a number of decades. And this is an early study from Mike Seil showing that in patients with heart failure with normal EF compared to controls, these patients have overall worse diastolic dysfunction and elevated filling pressures. But diastolic dysfunction is likely not the whole story. And this is an older study from David Cass and colleagues of looking at invasive hemodynamics in normal controls, patients who are young, older, those with hypertension, and those with heart failure with a normal ejection fraction. And really what we see here is that in the heart failure population, again, abnormal filling pressures and elevated diastolic dysfunction parameters, as well as abnormal contractility, and that vascular and ventricular systolic stiffening likely plays a significant role as well. And in general, EF is not always necessarily normal, so to speak, though we call this heart failure with preserved ejection fraction. Here's a study from Barry Borlaug and Maggie Redfield showing that in echo studies of hypertensive patients as well as those with Hfpef, LV systolic stiffness matches increased after load, but when we progress to Hfpef, there is impaired myocardial contractility and increased passive stiffness. So contractility, not necessarily normal in this population compared to hypertensive individuals. Here's a study recently from our group led by David Cass and Imran Islam looking at cardiomyocytes and contractility in patients with Hfpef that were grouped into a hypertensive phenotype versus an obesity metabolic syndrome phenotype. And what we found was that the obese patients, or the most obese in our cohort, had the most impaired sarcomere contractility compared to the hypertensive phenotype. And this was quite unexpected, but again, suggesting that contractility is not normal. And then globally, when we take a step back, there are probably pathophysiologic mechanisms that are more than just the heart. Here is a schematic from a review that we wrote showing various multi-organ system pathophysiologies that likely interplay in Hfpef in these patients who have numerous comorbidities. And I won't go through all of them, but you can see how complex this can look in a Hfpef patient today. Finally, one of the key mechanistic paradigms of interest right now is an inflammatory model of Hfpef, whereby obesity, hypertension, diabetes, COPD, and other comorbidities lead to an inflammatory cascade that eventually affects the myocardium and leads to increased fibrosis, hypertrophy, increasing stiffness, and this is actively being explored by many groups at this time. We finally have recently published myocardial transcriptomic studies trying to understand gene expression in Hfpef and found that Hfpef has over 4,000 genes that are uniquely differentially expressed compared to heart failure with reduced ejection fraction, suggesting that these are in fact distinct entities. And that within Hfpef, when we look at downregulated mechanistic pathways, these tend to be enriched for pathways such as protein processing, autophagy, angiogenesis, and these are not necessarily affected when we control for comorbidities. But that when we look at upregulated gene expression pathways in Hfpef from the myocardial tissue, these are enriched for oxidative phosphorylation, electron transport chain, and mitochondrial ATP synthesis, and very much influenced by comorbidities. We lose those enriched pathways when we adjust for BMI, age, sex, and CKD, for example. So much is to be learned from a mechanistic standpoint, but I'm going to segue to the latest in definitions and diagnosis of Hfpef. So going back to the 2013 ACC/AHA guidelines, you can see here that the definitions were very broad. EF greater than 50%, signs and symptoms of heart failure, and maybe prevalence of or presence of diastolic dysfunction, similarly from the ESC guidelines, but we have come a long way from these guidelines. In 2020, the ESC published the Hfpef algorithm. So this is an algorithm really targeting clinicians, beginning with an initial clinical workup, diagnostic testing, including echocardiography and natriuretic peptide scores, and then more specialized testing depending on the certainty or lack thereof of the Hfpef diagnosis. They groups the criteria into major and minor criteria, and you can see the scoring algorithm here, including functional, morphological, biomarker criteria, as you can see, and provided an algorithm for evaluation of the breathless patient with exercise intolerance, whereby a score is obtained, and depending on whether low, intermediate, or high, further diagnostic testing, such as invasive or non-invasive exercise testing, can be recommended to confirm the diagnosis or rule out Hfpef. Analogously, Barry Borlaug and colleagues developed the H2PEF score, again, looking at clinical variables, including BMI, comorbidities such as hypertension, AFib, age, and filling pressures assessed by echocardiography, also assigning a score and a probability of having Hfpef. In this algorithm as well, if there is an intermediate score, there is a recommendation for more specialized testing. Finally, there are numerous attempts at phenotyping in Hfpef, and there are many different ways to do this by comorbidities, clinical presentation, hemodynamics, cardiac versus non-cardiac presentations, biomarkers, and increasingly all-encompassing machine learning approaches. Our group is increasingly interested in myocardial tissue to phenotype this population. There have been some suggested phenotype match to treatment algorithms to help practitioners target therapies to the predominant clinical presentation or comorbidities. And this is a nice schematic from Sanjeev Shah and Walter Paulus that might be of benefit and help in clinical practice. But ultimately, we have some gaps between identifying phenotypes and targeting therapies. So in summary, the prevalence of Hfpef continues to rise, mirroring metabolic comorbidities at the population level. Improved consensus guidelines for Hfpef diagnosis are needed. Improved strategies to phenotype Hfpef are needed. And overall, a further understanding of disease mechanisms is really very much needed to understand the multiple pathophysiologies implicated in Hfpef and to eventually target therapies to the correct phenotypes. And with that, I thank you for your time, and I hope you enjoy the rest of the Congress.